I want to call up to the stage a man who needs no introduction, the current chair of the CSRS and a past chair of the section, Dr. Christopher Shaffrey, who's going to talk to us about the future of spine surgery from a neurosurgical perspective.
Well, it's always tough to follow my friend Larry Lenke, who has such great insights. These are my disclosures. So, in a nutshell, I think the future of spine surgery as a whole, and I think the difference between neurosurgical care and orthopedic care is diminishing. But I think there's going to be greater collaboration, there's going to be improved data collection, analysis, and planning, there's going to be individualized surgical treatments, there's going to be optimization physiologically, there's going to be enhancement of intraoperative techniques, and there's going to be an increased role in predictive analytics that you heard so wonderfully in Juan's presidential address. So one of the things, it's always hard to predict the future. These were all things that were supposed to have occurred by 2020, and not exactly all of them. I certainly am not in my flying car yet, but again, there's always a little bit of prediction. But one of the things for us to understand what the future is, we also have to understand what the past is. So this was at the Society of Neurological Surgeons, a senior society meeting, and Joe Ransohoff was giving his presidential address about why neurosurgery should stay within the arachnoid. And he said, academic and spine surgery is an oxymoron. No self-respecting neurosurgeon would ever focus their career in spine surgery. Spine surgery should be left to those who are either too stupid or too technically inept to do anything else in neurosurgery. So that's where we, as a group, were starting from. So what's happening is right around the same time, there was something called the Spine Deformity Study Group, and you can see the leaders, people like Keith Bridwell and others that were in that group who were the real leaders. And there were leaders of spine surgery and they're leaders of orthopedic surgery, and several younger people, as you can see, who have been, almost all of them at this meeting, have been there. And basically the two neurosurgeons, the young people, were Steve Andra and I that had been invited to attend. And these young people are people to this day who I am close and dear friends with, and we've worked together for collaboration. Now, one of the things which I see is I actually have got some concerns about what's going forward in the field of orthopedic surgery and orthopedic surgeons going into spine surgery. And this shows the current breakdown. The red star is finishing orthopedic residents doing spine fellowships, and you can see it's just about exactly the same as people are going into foot and ankle. So again, it is not the stellar, and what's happening is this has been seen, this wonderful paper by Bob Heery that shows during training, that most neurosurgery residents will do thousands of spine cases, and many orthopedic residents will do under 100 during the course of their entire training, which is creating some degree of a discrepancy. So what's happening is that I think that this organization itself has been at the absolute forefront of collaboration, and these are the more recent past chairs, and almost every one of them, if you went to the opening reception, you saw all of these individuals that were wandering around who are still very, very engaged, which something that is very unique. But these people have had a mantra of collaboration and engagement, and it has been a mission to have many orthopedic spine surgeons and spine surgeons as a whole involved in this. And here is the current joint section leadership. Several of them are up on the podium here. And what I would say to Dr. Ransohoff, you were wrong. That the spine surgery community is amongst the best and brightest and technically adept. And I think that we are leading the field forward as much as any other subspecialty in neurosurgery. Now, one of the things which I've been happy to be involved in is, furthering this collaboration. I think we all work together. Our mutual adversaries are not each other. They're the insurance companies, and sometimes there are hospitals, and sometimes there's people that are providing non-operative spine care. And so what's happening is between the Scoliosis Research Society, there's been increasing collaboration and engagement with neurosurgeons. I'm the current president of the Cervical Spine Research Society. And again, there's a major effort for universal engagement And even within the AANS itself, the number of people that are spine engaged, from myself and Reg Haid and Tony Asher and Shelley Timmons and others, are just very, very involved in spine, and the world is changed for us. Now, what's happening? This collaboration has resulted in some spectacular things. And we have our award winner, Shay Bess, here, and Shay was one of the leaders. You see Larry and a variety of other younger surgeons. They were part of something called the ISSG, and these are the ISSG. This is one of the studies and the people that are involved in it. And what's happening is the ISSG has had approaching 600 publications that have emerged from this data, from this multi-center collaborative effort amongst orthopedic surgeons and neurosurgeons. And some of these have gone, and this is a paper to show the impact of what has occurred for the ISSG and ESSG members. And what this showed was that we are doing things 50% better. 50% fewer major complications and 50% improved outcomes over a 10-year period of time by enacting what has been learned from the ISSG and ESSG. And what we're trying to do is to promulgate that throughout the entirety specialty. And these are some of the high-impact articles. Larry mentioned the use of TXA, which is something that was confirmed in its safety. You know, it was thought to be all of these antifibrinolytics with a high risk of stroke and heart attack and other thromboembolic events, and that just hasn't been the case and has allowed us to do it. The use of multiple rods and the use of better alignment techniques to reduce the mechanical complications that Larry showed so eloquently in his talk. Now, one of the things that neurosurgery has done well as a specialty is it is really focused on the use of data to improve clinical practice. And Bob Harbaugh and Tony Asher were really leaders for something called the Quality Outcome Database. And what the goal was is that every neurosurgeon could go and benchmark their data against other neurosurgeons to go and improve practice universally through that. Praveen Mohammadeti is one that really spearheaded the effort in spine, and you can just see, I think, you know, this is almost 1,000 publications have resulted from this QOD effort that the AANS supported, and particularly, acknowledgement needs to go to Bob and Tony with that. This is morphed in the spine to something called the American Spine Registry. This was, again, a collaborative effort, and you can see the original executive committee for that. And this just shows you some Duke data where we're using ASR data. We've put in over 25,000 spine cases at Duke into ASR, and we're using this on a daily basis to improve our clinical practice. So this is what we do at Duke, each month. This shows all these tiles, our different outcome metrics that we're looking at. Orrin Godfrey, one of our neurosurgeons, just an absolute data guru. And with this, each month we have a tile that comes to us and gives us a scorecard about how we're doing on things from surgical site infections to readmissions to patient satisfaction. And this data has been driving us better. And we at Duke over the last 5 years have improved our outcomes about 40% with data-driven improvement. So what's going to also happen more globally is we're going to use this radiographic data for both simple and complex spine surgery to improve our outcomes. And we're going to use physiologic data, which you're going to see in a minute, to go and improve what we are doing by increasing people's ability to tolerate surgery. So one of the things is, when I was first starting out, we thought that adults with scoliosis were like big kids. And what we found is that for most adults, it is actually a degenerative collapsing process. It's not the same as what it is for most people with idiopathic scoliosis. So through some work through the Spine Deformity Study Group and through the ISSG, there was a new classification system that looked at different parameters using data to go say what are the different areas that are principally important for the generation of symptoms. And this is, again, one of my patients from several years ago, showing somebody that was severely malaligned and how realigning them using this kind of data just absolutely transferred their life. Somebody who is severely disabled to somebody who is basically normal by all of our disability indices. We've learned the impact of age and how it impacts this radiographic analysis, and we've looked at certain factors for particularly the extremes of spinopelvic alignment and how this alters potentially how we're dealing with some of those patients. Some of this work, though, also has simplified things, showing that having about 35 degrees of lordosis between L5 and S1, no matter what your pelvic shape in, is nearly universal, and if we can achieve that, we are almost certainly going to have much better results when we're doing our simple or our big surgeries. And Larry had mentioned this wonderful article by Mike Kelly and his team. And basically, I think we have almost figured it out. Now you're going to see that this isn't easy, and not all of us are drawing all these angles and doing that. But that's going to come. You're going to see in the next 2 years the ability to have this done for you automatically is right on the horizon. So what's going to happen is the ability to go and to analyze this data automatically, to calculate, or allow you to calculate what exactly the ideal alignment is going to be using these parameters, and eventually using patient-specific implants both for rods and for inner body techniques to be able to go and to treat these people most effectively. Now, one of the things which has been a passion of mine has been how do we reduce complications? And the fact is that our results are fabulous, as you saw Larry mentioning the adult symptomatic scoliosis study. But the problem is our complications are still too high. So there's an increased recognition that frailty is central as far as these complications. And what happens, both these patients are 79 years old, and which one of them do you think is going to do better with surgery? So what's happening is we have found through work through the ISSG that the patients who absolutely do the best with our adult deformity cases are people who are frail, that the deformity has impacted their health. But severely frail people do terribly because of the massive number of complications. So if we can convert people from being severely frail to frail, we suddenly have the sweet spot of people that we can absolutely extraordinarily help. So the question is, how do we alter frailty? And these are some of the things that we're doing at Duke to go and improve nutrition, to do other different factors, blood sugar control, bone health, other things that we're doing to go and reduce frailty. And what's happening is by doing this, we have been able to go and assess this, and this is some work through ISSG led by Shay and others to go and test frailty and alter the frailty curve to make people from being severely frail to reduce the number of complications. Some work from Chris Ames and others in the ISSG are looking at proteomics and other factors to be able to go and with a blood test determine someone's frailty and how the frailty can be improved. Lastly, there are a variety of intraoperative techniques that we're using to go and to improve what we're doing in surgery for reconciliation, to get the alignments that Mike Kelly shows us that are so important. And there's different things with improved intraoperative real-time imaging, trying to get rid of reference arrays and other things to make this safer and more effective. Big data is going to be increasingly important in the use of AI. And this is, the words predictive analytic spine and surgery, and you can just see it's just blowing through the roof. And it is the future of what we're going to do. And it's something that, again, is a passion of us moving forward to help us move forward, but also to tell us, hey, look, this is not the patient you should be operating on. This person is too frail, too ripe for complications that we don't want to do it. And what we want to do is we want to select the subgroup of people that we're going to go and we are absolutely going to help the most. And one of the things that we're doing at Duke is the use through Epic of something called Pythian, where we're going to have the ability for everyone in this room to have a risk calculator as sophisticated as what we use with the ISSG. So again, we know what the alignment parameters are. We are probably a year to two away from this automatically being automated for us to know what we're doing. So in conclusion, I think improved analytics and planning, individualized surgical treatments, optimization physiologically, and all these factors are going to help us move forward and do a better job from a spine surgery perspective, and this is what the future is. Thank you.